Hi, everybody. I'm Angie Rasmussen. Sorry, once again, I have tripped over my own lack of production skills. So apologies for a bit of a late start. Today is going to be a fairly quick episode. And even though I promised initially that I was going to share slides and teach a class on Ebola virus, Jessica and I think, are going to do a longer show since she was unable to make it this morning for our update show. And we can go over that kind of thing then. I don't know that you guys actually do tune in so that you can experience the joy of sitting through a virology lecture with me. Anyways, we do need to talk about the Bundibugyo virus outbreak, the Bundibugyo Ebola virus outbreak that is occurring in the Democratic Republic of Congo and Uganda. Right now, we have a really serious situation in that we have more than 900 cases. We have more than 220 deaths. These are all suspected, and it should be noted that we don't know for sure if these people actually did die from Ebola. There are a lot of other diseases in this part of the world that can be confused for Ebola. So I actually put out a Substack yesterday afternoon. I had a fun Memorial Day weekend because it's actually not a holiday in Canada. But I wrote up a piece on why Ebola is not going to be transmitted by the airborne route anytime soon. There are a lot of biological reasons for this, but one thing that strikes me is that actually Ebola is not a hemorrhagic disease as often as people think that it is. I was talking today with one of my friends who is an Ebola survivor. He was telling me that, a lot of people had thrombocytopenia, which means that they had lower platelet counts. But in general, Ebola is actually a gastrointestinal disease in many people. People lose insane amounts of fluid because when it comes right down to it, Ebola pathogenesis is a disease of an aberrant host response. So the host response to infection often determines whether or not a person is going to get really severely ill, because when those host responses don't actually effectively clear out the virus, they get thrown out of whack, and the host immune and inflammatory response are extremely powerful. But they are meant to be applied to a specific injury or infection. When they are systemic and uncontrolled, as they are in Ebola virus, it causes problems throughout the body. But one of the biggest problems is the ability to keep fluids in places. So there's a lot of vascular leakage. That's the famous hemorrhagic syndrome. But that really is not so much an issue of bleeding. It's a matter of the circulatory system not working to keep blood inside of it anymore. And the same thing happens in all organ systems, basically, that serve as some kind of barrier, with one exception, the respiratory tract. Ebola doesn't actually do that much with the respiratory tract in most cases, but people who do have lung disease often have pulmonary edema. Again, that's probably because of the loss of the ability to regulate fluids in different compartments and across membranes. So one of the results of this is you can have really severe gastrointestinal disease with no evidence of the hemorrhagic syndrome. And so as a result, Ebola can look like a lot of different things. There are hemorrhagic manifestations of malaria as well. So somebody with Ebola could be confused for someone with malaria. There's a lot of symptoms in common that are more vague symptoms like headache and fever and things like that. Can be confused with a lot of different kinds of gastroenteritis. Can be confused in some cases with sepsis. Very severely ill patients sometimes seem like they have bacterial sepsis, which is also a disease of widespread and uncontrolled inflammation. It's a bacterial infection, but that's what the bacterial infection causes. Just like the Ebola virus infection causes Ebola virus disease, which is effectively a way when the host responds to the virus infection in a way that is not helpful to the host and it doesn't have an antiviral effect or isn't effective at clearing the viral infection, then Ebola virus disease results because of this abnormal hyperinflammatory state that the person gets into. So that's how Ebola virus kills you. That's also why it's not going to become airborne, because it infects cells that are not in the lungs, but it's also why it can be confused with a lot of different things. So if we get back to the original topic, the case counts, I think that one thing that's really, really important to point out to people is just that a lot of these are unconfirmed suspected cases, and they could end up being something else. That said, they are increasing throughput in terms of testing. So, we have had a real problem in this outbreak with access to necessary supplies, personal protective equipment for people who are working as healthcare workers, people who are working in response, people who are working to carry out safe burial activities, which is becoming a real problem due to the fact that there is a huge amount of distrust towards public health authorities. Now, I do want to point out that in 2018, there was an outbreak in North Kivu province in the Democratic Republic of Congo of Ebolavirus. And some of the same things happened during this outbreak because there is so much distrust, especially of government people, but in general of international public health workers. And there is a really shameful history of going to countries like the Democratic Republic of Congo and extracting essentially biological resources from them and not giving them any credit. And one thing I actually did want to bring up today and point out to people that's very academic is that my colleague, Lawrence Gostin and Alexandra Phelan and Jennifer Nuzzo, they are all experts on international law, on public health and global health, have written this piece in the Lancet that's out today. And this describes like some of the things that we actually need to rebuild this trust. And one of those key components is making sure that when we are organizing a plan for responding to pandemics, when we're coordinating outbreak responses internationally, in the absence of the US being a driving force, we need to build a system that is going to actually partner with countries like DRC and Uganda and not treat them as places that we are going to send people to, get stuff, go back to our countries, develop intellectual property, write fancy papers and big journals and take all the credit, and leave our Congolese and Ugandan colleagues high and dry effectively. Things have improved in this regard in my field significantly, but they are still not completely solved as far as those problems go. And I think that this is something that we really need to reckon with, because the reason that we are experiencing all of this violence directed towards clinic workers is that there really has been so much distrust historically, including in other Ebola virus outbreaks, that we really need to work on this. This is going to be essential for containment. Now, there are two situations that lead to spread and drive transmission in Ebola outbreaks. One of them is being in the hospital or caring for Ebola patients, healthcare workers, nurses, doctors, but also family members caring for people at home who might not think their loved one has Ebola. Maybe they think they've got malaria, they've got a headache, they've got fever. It's not obvious that they have Ebola. There's also a tremendous stigma associated with getting Ebola. So people are often very reluctant to think that they might be at risk for having Ebola. There's a lot of reluctance to basically expose themselves to that type of potential social stigma. It can have lasting effects on people, and Ebola survivors have described in really heartbreaking terms, actually, about how they're not able to get jobs, they're not able to participate fully in society, simply because they had Ebola virus and they survived their infection. So there is a serious problem in terms of our ability to manage a really complex social and cultural context. And that's why it is really, really important that when we are talking about this outbreak, we're not talking about it in these sort of sensational fear-mongering terms. We're not thinking about it in terms of, oh, what if an Ebola patient gets back to the US? We really need to be thinking about this in terms of how do we control this outbreak, because this is a terrible, terrible disease. I wouldn't wish it on my worst enemy. I don't want to get Ebola virus disease ever from the people I know who have had Ebola virus disease. They either don't remember it or remember being sicker than they've ever been in their life. Ebola is a terrible, terrible disease, and it matters for the entire world that we all make our best effort to prevent any new cases of Ebola virus. And in this outbreak, that is just unfortunately going to be a huge problem. Now, before I move on, I do want to sort of underscore what I said about trust with my co-host, who is, again, actually doing Ebola-related work right now in a different meeting, but who I'm going to get together with hopefully later today for our regular now Tuesday afternoon episode of our show, Taking Shots, which we didn't do on Friday either. But guess what? We both have other jobs. So she's still going to be here because I'm going to play.
In the Democratic Republic of Congo, according to the World Health Organizations. Today, officials upgraded the risk level for Ebola from high to very high in the DRC, while keeping it at high for the region. The threat, though, does remain low for the rest of the world. The organization also warned the epidemic is likely larger than the nearly 750 suspected cases and 177 deaths. I want to bring in Jessica Malati Rivera, who joins us now. She's an infectious disease epidemiologist and executive director of the Infodemiology Initiative at the Public Good Projects. Good to see you. Just looking at what we know so far, what does it tell you about the potential scale of this compared to the 2014 outbreak, for example?
So, as you mentioned, we're already at 750 suspected cases, 175 suspected deaths, numbers that, as you mentioned, are likely an undercount considering the fact that we are playing catch up on an already delayed response. If you want to compare this to the 2014 outbreak, an outbreak that lasted nearly 2 years, this could be the beginning of a very long outbreak. It is something that we are just now starting to understand because this, again, while this is the DRC's 17th outbreak of Ebola, this is only the third time we have seen an outbreak of this particular strain, the Bundibugyo one. It's much rarer, and we don't have the same type of tools that we had in before, including the molecular diagnostics that are different from diagnostics that would identify another outbreak, say, involving the Zaire strain. And so it is potentially much larger than what we're seeing. There are some models that suggest that it's up to 1,000, perhaps more. And right now we are just in a very, very acute time of figuring out the exact scale of this outbreak compared to the other ones.
And I just wonder right now, what factors are you watching most closely to indicate maybe that health entities are starting to get their arms around this, or would indicate that maybe they're making some real meaningful progress? What are you watching there?
Well, the one thing that is encouraging is noticing that there are some cases that were suspected that have tested negative after they did have the right molecular diagnostics made available to them. But again, what I'm actually really concerned with is the fact that because this went on for so long, it has made something, one of the most effective strategies in infection prevention and control, contact tracing, that much more complicated because you have a hard time knowing exactly the spread of an outbreak unless you can do that type of door-to-door outreach in communities, identifying all close contacts who may need to be quarantined or isolated if they're sick and symptomatic. This requires a big network of community health workers and epidemiologists. And so while we are seeing some suspected cases come out negative, I'm more worried about the cases that we've missed, the cases that we haven't even identified as potential close contacts.
You know, we have some new CNN reporting that has some insight into how USAID cuts could be affecting this outbreak. Surveillance, obviously, a big part of stopping something like this in its tracks, as you mentioned, being able to contact trace in the beginning. The International Rescue Committee, who has workers on the ground, says U.S. funding cuts contributed to delayed detection of the virus. The State Department, though, disputes that changes under the Trump administration hampered those efforts. An official told reporters there was no specific person or program associated with USAID in this region that would have detected this or contributed to a detection framework here. But bottom line, how does disease surveillance actually work on the ground in a place like the DRC?
Well, first, I want to say that bottom line, that is not true. There were systems in place that were in place in that region that would have absolutely been able to respond to this, the first signals of this, possibly within hours. Because again, Ebola is not new to DRC. It's not new to the region. There were systems in place specifically to have rapid response and surveillance systems activated. And because USAID was gutted, because so many of our partners did not have the resources, they're doing it without the resources and without the personnel to do it. And we're throwing, very small amounts of money to I think, assuage some of that guilt. I mean, I think I read $23 million and 50 50 treatment clinics. If we look back at the 2014 outbreak, we contributed hundreds of millions of dollars, and those actually took months to build. And so it's deeply troubling that we're even having this debate, because we know that these shortfalls are directly linked to the defunding of USAID. And we have seen on the ground people say that people who are having to move suspected cases are doing so without proper PPE, sometimes without gloves, sometimes with barely even a mask on. And those are the types of things and infrastructure and supplies that USAID was directly involved in, including things like contact tracing and community outreach and comms education and diagnostic testing. It's a whole network of systems to do infection prevention and control. And we're basically just doing it, in piecemeal.
And it seems to this point that the rest of the world is playing catch up to figure out what the extent of this actually is, since it seems we missed that contact tracing opportunity in the beginning. Got to leave the conversation there. Jessica Malati Rivera, thank you for taking the time.
Thanks for having me.
All right. Meanwhile,
Well, that was pretty good. I couldn't have said it better myself. And in fact, I couldn't have said it better because, unlike me, Jessica is actually an epidemiologist. So what she studies is how viruses move through populations. And every point she just brought up is exactly why this outbreak is now pushing the upper limits of last week's Imperial College modeling projections that said that, these cases would potentially be as high as 900 cases. We went to 900 cases yesterday, at least suspected cases. The problems with contact tracing that Jessica brought up are very much going to hinder our ability to control this outbreak. Contact tracing, these tried and true techniques for controlling not just Ebola virus outbreaks, but all kinds of outbreaks. This is a standard epidemiological method of controlling outbreaks. You identify cases, you isolate those cases, you find their contacts, you quarantine them. Anybody who does end up becoming a case is then isolated. All of the contacts are traced. So you can take it out to, tertiary contacts, third level contacts, manage all of those people. Now, in conventional Ebola virus outbreaks, there are 6 different species of Ebola viruses, and the vaccines will only work for each individual species. Ebola virus is another species than Bundibugyo virus, which is the species of Ebola virus that is causing this particular outbreak. So there is a vaccine for Ebola virus. That is the conventional OG Ebola virus that everybody knows about and thinks of when they think of Ebola. One of the things that has been extremely successful since it was rolled out in 2018, I believe it was approved by Merck's vaccine was approved. They couple contact tracing with what's called ring vaccination. So they vaccinate all of the contacts out to, I think, the 3rd level. And this expanding ring of vaccination prevents people within that ring from getting Ebola. It also stops the spread to people outside of these contact networks. So that's something we don't unfortunately have for Bundibugyo virus, because this virus was so rare. It previously only caused 2 fairly small outbreaks, one in the DRC, one in Uganda, one in 2007, one in 2012. This outbreak has completely dwarfed both of those in terms of its size and scale. And we don't have a vaccine. These vaccines for Ebola viruses have been tested preclinically, meaning they've been tested in animal models. But nothing has been done to assess their safety in humans, much less their effectiveness, because there haven't been big outbreaks of Bundibugyo virus until now. Unfortunately, that means that we won't have a vaccine anytime soon to apply this ring vaccination strategy to. So we're just going to have to rely on the older methods of making sure that we can isolate and quarantine. And once again, that comes back to contact tracing. Now, when we've had this problem of clinics being attacked, effectively being, the local community is not down to participate in these public health orders. And that is understandable, because there has been a very, very long history of problematic interactions with public health officials, among others, in DRC, in this part of DRC. So that means that, there is a lot of trust that has to be built and a lot of distrust that has to be overcome in order for us to actually effectively do contact tracing. We won't be able to control this epidemic without contact tracing. And, I fear that a lot of these suspected cases are actually going to be Bundibugyo virus. If that's the case, then it makes me wonder really how long this has been spreading, because we don't have very much phylogenetic or genomic data so far. And that's how we would really be able to tell with certainty. But we don't have a lot from early on in the outbreak. We have a report of some aid workers who were responding to a different humanitarian crisis, who were infected with Ebola while handling dead bodies, which is a very, very common way of getting Ebola. And that was on March 27th that they were infected. So if you assume that the dead body that infected them with Ebola probably was infected for 2 weeks-ish, that puts us back towards the beginning of March. So it's been going on for 2 months. But this is a really, really steep trajectory for this outbreak. And again, it could change if some of these suspected cases are not confirmed. I hope that is the case. I hope that we aren't looking at what we're looking at, because based on the number of cases and the time, if we compare this to the West African epidemic, this is already bigger. The West African epidemic also wasn't effectively responded to for several months, but it smoldered before it ended up in the cities. That's where it really got out of control. This outbreak is already in major cities. It's already in major population areas. It is in an area, a very large area, by the way, that's like the size of Florida. This is a huge part of the DRC, and Africa itself is a huge continent. We are really talking about a large geographic area here when we're talking about this. And we're talking about a highly mobile population that is being displaced by conflict, by some really, really complicated political scenarios. And that is just going to make it incredibly, incredibly difficult to effectively contact trace and to really shut down all of these different chains of transmission. So, the West African epidemic lasted for almost 3 years. Started at the end of 2013, and it wasn't until the middle to the late 2016 that it was actually declared over. I feel like this is something that could go on a lot longer, just because there aren't the same challenges. I mean, there was some distrust of public health in the West African epidemic, but I don't think it was like this. And I don't think the conflict was there wasn't conflict. There was distrust, and now there's conflict and distrust, and a situation that I don't pretend to be an expert in. I'm an expert on the virus and how it infects people and causes disease. And because these viruses, I know, spread and can infect people and cause disease in them pretty easily, given the right circumstances, given exposure to dead bodies, given a lot of people in the healthcare system needing treatment, which Ebola epidemics cause a lot of both of those things. We're potentially looking at a health crisis that is historic for Ebola viruses, and not in a good way. And we really do. I just want to leave everybody, now that we're coming up on 30 minutes, and I'm trying to be responsible with how I use my time, because I know you guys don't have all day to sit around listening to me jabber on Substack. I just want to end by emphasizing that we can't control how many people Bundibugyo virus kills, right? So we don't really know what the case fatality rate is. Historically, these outbreaks have been lower than regular Ebola. In the West African outbreak, depending on which population, depending on what access to care services people had, the mortality rate was roughly around 50%. That's still really, really high. It's not 90% like in the first outbreak, but it's still extremely high. Bundibugyo virus has had about a 30 to almost 50% mortality rate, case fatality rate in past outbreaks. in this one, again, because we don't know if all these cases are actually Bundibugyo Ebola virus, we can't really assess the case fatality rate yet. But we will be able to, if it's a little bit lower, who cares? To be perfectly honest, 30% mortality is still unacceptably high. So we can't do anything about that right now with the tools that we have. Hopefully we can try to crank out some monoclonals or something really fast, but we don't have them right now. We can't alter the pathogenicity of this virus. So what we have to do is to try to make sure as many people as possible don't get infected with it. And I just worry that because of what the US has done, because of what my country has done, abandoning its obligations and its own commitments and investments in this part of the world for people who really need it, because the US used to think that it was part of our value system to preserve global health and to make sure that as few people died of a terrible disease as possible. We've abandoned that attitude. And now we are seeing what are effectively preventable Ebola virus deaths, because we can't control if this virus is going to emerge. We can't control what it does once it infects a person. But we have in the past effectively stopped these outbreaks by controlling how many people can get infected and by keeping people safe and out of harm's way so that they won't get infected. And we're not able to do that anymore. People don't have enough PPE on the ground. There's this conflict situation that is complicating things incredibly, and there's no support for additional security for international teams. We're still having shortages of reagents used for molecular diagnostics. People are still not able to get to areas where they need to do contact tracing. So we're really, really behind. And Tedros, Director General of the WHO, yesterday admitted that, said that the outbreak was outpacing us. So we really have a lot of work to do to play catch up. I think Jessica and I will be back later today for a conventional chit chat on our regular show, Taking Shots. I'm Angie Rasmussen again. Follow me here or at rasmussenretorts.substack.com. Feel free to subscribe. It's free. And follow Jessica too, makingsciencemakes.substack.com. You can find us both on Instagram. You can find me on the Health site X. You can find us on Blue Sky. You can find us everywhere. We'll be back tomorrow and probably later this afternoon. Thanks, everybody. Stay safe.